So let's just take a second and talk about what accountable care is. It is an accountable care organization, really is based on a few specific attributes, and it's where providers are coming together to pick up the payment risk as well as the care delivery risk for specific populations. They are traditionally made up of different provider organizations, and they're really focused on providing the right care to the right people at the right time and in the right place. So place of service becomes very important in this model because you're trying to find the lowest cost care setting for the best quality and outcomes. And they are trying to avoid unnecessary care, obviously, and they're also very anxious to push reward and risk down to their partners as well. And that in and of itself starts to shift how the market is working. So let's talk a little bit about the history of ACOs. Sorry, my clicker's not clicking. So back in the 80s and 90s, and I was around for them. I was pretty young. I was very young, but the HMOs that came out were really an attempt to try to manage the cost and quality of care through controlling where people had access to care. And we know that sort of failed spectacularly in its way. And I'll just, as a plug for data and analytics, say that one of the reasons that it was such a struggle and why the industry ultimately rejected it was the data wasn't there. And with the coming in the 21st century of new forms of data, the ERA High Tech Act, adding the ACA, you're starting to see the data become available, and most recently ONC and CMS have both put non-data hoarding rules out there to establish more ubiquitous sharing of data. And that's allowing these accountable care organizations to thrive because they now can see what's going on where before they could not. So in 2005, we started that accountable care journey essentially with the physician group practice experiments that were going on, and they were looking at how they could drive more valuable care for a better cost and better outcomes. 2006, this term ACO first came up, and I want to credit Health Affairs. I may be not right about that, but I think it came out in an academic peer-reviewed journal, a study that said that seniors tend to, once they choose a provider, they tend to stay with them, which would make this idea of accountable care without curbing patient choice, which is the key, possible. And so by 2010, when the ACA came around, we now have this ACO model and what that means written into the law. It also established the ACA, the CMMI, which is the innovation arm of CMS, which allowed CMS to carve out experiments to start to change how the value of care is delivered in our country, and test out these new payment models that they're interested in. And that became really important because what you're going to see now is the sort of reiteration and the rapid experimentation of CMS with lots of different models. They all sort of build on each other, which is why they're confusing, and it's hard to know who does what and which one has which rule. But it was the beginning of the iteration process of CMS, trying to explore how do we end fee-for-service and go to a model that's more controllable. Pioneer started in 2012, MSSP, which is the Medicare Shared Savings Program, those followed shortly thereafter. Next Gen ACO was a new ACO model that was building on the successes and failures of the Pioneer and the MSSP model. And last year, they changed the MSSP model into the Pathways to Success program. And so as you can see, they kept iterating over and over, adding new tracks to the MSSP. And now here in 2021, we have the beginning of the direct contracting program. And we'll talk about that more in just a minute. It's technically part of the Primary Care First program, but it is built upon all of the successive ACO experimentation that CMS has been doing for the last 10 years. And so in a way, it is an ACO in and of itself as well. So types of ACO models, I've mentioned them a little bit. The pioneers started early, and they were mostly health systems that had some experience with taking on risk. It was not, it was not for the faint of heart because you were jumping in completely blind. CMS was figuring it out as they went, as was the Pioneer ACOs. There was risk and reward in this model, and you'll see that over time there was a lot of attrition. It was the first foray, and so there's a lot of lessons learned. Some learned they weren't as ready for risk as they thought. Others were able to successfully manage it. But moving into the MSSP, where there was more upside risk in the early days and less downside risk, you saw some of those models, folks move over into that model where they could handle the risk problem a little better, continue to refine how they did their business, and try to make the MSSP program a success for themselves. Next Gen, again, offered new ways of thinking about ACOs. I think one of the biggest things that it did was it made the financial targets more predictable. They took a good hard look at the benchmarking and how they, prepayment and things like that to try to make it less dangerous for an organization to take on that much risk with a retrospective attribution model. And that retrospective attribution model is a big deal. It's really what makes ACOs different than MA plans, not the only thing, but one of the key things. Where MA plans know who their population they're serving is, they can account for the risk of that population. An ACO is retrospectively being assigned people who got their care and services from the ACO network after the fact. And so anticipating the risk and actually being able to manage it is much more challenging in an ACO environment.